newborn. The overview of this presentation, we'll be dealing with the case scenario, the usual definitions, peristomal skincare, complications of ileostomy, adaptations of the bowel, ileostomy diarrhea, nutrient deficiencies that are commonly seen, and we'll be summarizing it finally. We'll start off with a case that presented at our hospital. One baby of Sumaya, born on 28th of October, and baby was admitted on 3rd of November. Was born to a 24-year-old primey, and there was no maternal comorbidities in the mother. Emergency LSCS was done in view of meconium-stained amniotic fluid. Term male baby, birth weight of 3 kg, and the baby had soon cried after birth. Baby presented at 12 hours of life with abdominal distension and bilious aspirate. Per abdomen wise, there was gross abdominal distension. Tense abdomen was there with dilated veins. X-ray abdomen basically showed dilated bowel loops. Emergency laparotomy was done on day 1 of life. And what they observed was type 4 jejunal-ileal atresia with web in the proximal segment. Segment of ileum with multiple atresias was there. The proximal level was 40 centimeters from the ileocecal junction. The junction was preserved. And there was dilated proximal segment. Atretic segment was excised, total 23 centimeters. The intestine was divided into multiple segments and it was all connected by thin bands. And anastomosis was done. Post-operatively, abdominal distension and bilious aspirate still persisted. A repeat X-ray, which was done on postnatal day 4, showed pneumoperitoneum and the baby was subsequently referred to our hospital. Flank drain was inserted and a re-laparotomy was done on postnatal day 6, which showed anastomotic leak. Ileostomy was done in the left lower quadrant and distal bowel was brought out as the stoma. Ileostomy started working by post-op day 2. Feeds were initiated on post-op day 4 and it was gradually increased. Baby attained full feeds by post-op day 6. Initial ileostomy output was only 35 ml, but it progressively increased in the next week. On postnatal day 16, that is post-op day 10, ileostomy output was 240 ml, which was 80 ml per kg per day, and the baby also had progressive weight loss. That is, birth weight was 3 kg, and by the time it was postnatal day 16, baby was only 2.4 kg, that is 20% weight loss was there. Baby also had erosion of skin around the stoma. Stoma care was done with zinc oxide paste and later betel leaf was also used for stoma care. Baby also had hyponatremia. The serum potassium was however normal and venous blood gas done showed compensated metabolic acidosis. We can see an overview from post-op day 1 wherein the stoma output was nil. Post-op day 2, stoma output was 35 and it progressively kept increasing. By the time it was post-op day 16, stoma output was 230 ml with consistent weight loss of 2.47 kg was the subsequent weight. By the time baby was post-op day 21, stoma output was 180 ml, weight was 2.35 kg. So in view of high stoma output, IV fluids with sodium and potassium supplementation were given. High stoma output persisted, hence the baby was added on oral ranitidine. Loperamide was also added in view of output remaining persistently high. Various nutritional supplements, that is multivitamins, vitamin B12, magnesium, all these were also added. So coming to our topic per se, few neonatal conditions that actually require stoma includes meconium ileus, necrotizing enterocolitis, anorectal malformations, Hirschsprung's disease, intestinal atresia, intestinal malrotation, and volvulus. So let's familiarize ourselves to a few terms first. Coming to ileostomy. Ileostomy is an opening into the ileum, which is the last part of the small intestine, which diverts gut contents, which is usually liquid or semi-solid, through the abdominal wall, and it's then collected into a stoma bag. So stoma. Stoma is a surgically constructed opening of the bowel through the abdomen that diverts the flow of feces. The bowel opening is stitched during an operation to the skin of the abdominal wall in a position that allows a collection bag to be placed around it. Stoma output is basically the waste that is expelled from a stoma. This may be formed and it's difficult to measure, but the fluid proportion can, however, be measured and recorded as required. Coming to ileostomy. Ileostomy is a surgical procedure in which exteriorization of the small bowel through the anterior abdominal wall is done. It may be required for permanent or temporary fecal diversion. Colectomy is one of the most common indications requiring permanent ileostomy. Ileostomies can be fashioned in an end loop or an end or a loop fashion. So coming to the types of stoma, we have an end stoma. For an end stoma, the bowel is divided and the proximal end is brought out through the abdominal wall. The distal non-functioning the distal non-functioning limb can
I request everybody to kindly mute. Can all the participants please mute?
the distal non-functioning limb can be brought out through the same abdominal wall opening as the end stoma. That is a double barrel stoma, which is seen in the first picture, or it can be brought out through a separate incision, that is the mucous fistula, or it could be closed and simply left in the peritoneal cavity. Coming to the second type of stoma, that is a loop stoma. A loop stoma is created by maturing a segment of bowel over a rod or a tube without completely dividing the bowel. So this provides excellent decompression, and a simple closure only is required without the need for a separate laparotomy. But they are not completely diverting, and the proximal contents may simply spill over to the distal limb. So hence they should be used with caution in patients in whom stool in the distal bowel may be problematic. Ileostomies usually begin to function in 4 to 5 days. In the first few days, clear or serosanguinous fluid is what appears. The output from a stoma is directly related to the location of the stoma. If the stoma is located more proximally, there is less surface area for electrolyte and water absorption. The consistency of the output is usually soft, but that may be affected by various conditions, such as food and fluid intake, various diseases, such as active Crohn's disease, or any medication that the baby may be on. Skin characteristics of the premature neonates and children. So premature neonates in particular, they are at higher risk of increased heat evaporation and transepidermal water loss. The skin of the premature neonate is highly permeable. Premature neonates, they present a diminished cohesion between the dermats and the epidermis, which can actually lead to skin tearing, as in when we remove the skin barrier that is applied as a pouching system for the stoma care. So coming to peristomal skin cleaning, it is one of the most important goals is to keep the surrounding skin healthy. So we need to clean the stoma and the peristomal skin by using sterile water or lukewarm water and a soft cloth. We could use a mild soap which does not leave a film or any residue on the skin and then rinse it off with plain water. The skin should then be patted dry gently without any friction. Avoid using commercial whites as these may contain additives that can cause skin irritation or allergies. Various skin barriers that can be used. Barrier creams such as zinc oxide can be used. Betel leaf for stoma care and various pouching systems. So coming to betel leaf and stoma care, it's an innovative technique, which is, the study was carried out in Bangladesh. And of the 623 children who were studied over there, 287, all of which had undergone enterostomies. 287 had sigmoid colostomy, 211 had transverse colostomy, 105 had ileostomy, and 20 of them had jejunostomy. Of the 495 children who were placed under betel leaf stoma care, 13 patients, that is just around 2%, developed skin excoriation, and no allergic reactions were recorded. Of the 128 patients who used an ostomy bag, around 40% had skin excoriation, and 18% of them developed some allergic reaction to the adhesive that was used. So how did they go about the same? Initially, zinc oxide paste was applied on the peristomal skin. A betel leaf with shiny, smooth surface outwards and a rough surface inwards was placed over the stoma, with a hole made in the center according to the size of the stoma. Another intact leaf, which covers the stomal opening, was placed over it, and over the same, a cotton cloth made into a bag can be placed over it, which is simply removed on soakage. So it was beneficial in stoma care for a few reasons. It being cheap, easily available, non-irritant, and it's familiar for use. People are aware of the same in Southeast Asian countries. Allergy-free, and it covers a large surface area well, It allows the caregivers to view the wound at any given time. Third part, that is pouching systems. Skin barrier is the waxy part that sticks to the skin and it fits right around the stoma. It protects the skin from contact with stool, urine, or enzymes. It helps to hold the pouching system in place. The opening in the skin barrier should be the same size as the stoma. The pouch is the plastic bag that collects the stoma discharge. It is made of a material that is designed to contain the odor. The pouch should be emptied as and when it's 1/3 to half full of gas or stool. So the following factors must be assessed and documented when changing the stoma appliance. That is, how is the stoma, the size, the shape, color, and appearance? How is the surrounding skin? Is it intact, eroded, infected? Is there any allergic manifestations or any granuloma that is there? How is the mucocutaneous junction? Is it intact or separated? Characteristics of the effluent should be recorded, the consistency, quantity, as well as the color. In case of any leakage, the area of the skin involved, parents or caregivers' level of comfort with stoma care, and the signs and symptoms of dehydration should also be recorded. So this is a basic chart showing neonatal and pediatric stoma care chart. This was from Trust Guidelines. This is a basic overview of how to go about the same. Basically, the stoma bag needs to be assessed. Stoma bag changes, if any, should also be recorded. On an average, ileostomy output should be only 10 to 15 ml per kg per day. A doubling of the usual stoma output should be considered abnormal. So what are the various complications that can happen in a baby who has an ileostomy done? Skin irritation is one of the most common. It can be chemical, mechanical, or allergic. Intestinal obstruction, adhesion, stricture, volvulus, wound-related complications, prolapse, retraction, ulceration, bleeding, fluid and electrolyte imbalances. Coming to skin irritation. Skin irritation and infection, they are the most common complications with pediatric stomas. Excoriation from stoma effluent, candidal infection, and dermatitis, they are quite frequent. Improper location or construction of the stoma, and poor stoma care, these are the factors often responsible for the same. Local wound care, caretaker education, and occasionally surgical revision might be needed. Intestinal obstruction, which includes adhesion, stricture, and volvulus, it's also quite common. Stoma strictures can occur at the skin level, at the fascia level, or both. Other causes of obstruction include luminal plugging that is caused by ingested food, adhesive intestinal obstruction, internal hernia, and volvulus. Partial obstruction can result in hyperperistalsis and hypersecretion. Massive fluid losses can occur through the stoma and can cause dehydration. Wound-related complications, wound infection, wound separation, or dehiscence. They may also occur after the formation of a stoma, particularly if the stoma has been brought out through the wound. Stoma prolapse. This is also quite common in children. Prolapse can occur in end or loop stomas. Both proximal and the distal bowel segments can protrude many centimeters. A variety of surgical techniques have been used with mixed success to reduce the incidence of prolapse. Stoma retraction. Stoma retraction would result in a stoma that is flush with the skin or it retracts beneath the skin. Retraction would allow the proximal contents to simply spill into the distal segment. Usually, when stoma is temporary, only shorter measures are needed until the stoma is reversed. Permanent stomas that have retracted may require surgical revision. Psychological issues are another significant issue for the family. A team approach to providing pre-op counseling, post-op care, with participation of an enterostomal therapist or a nurse specialist is essential. Fluid and electrolyte losses from any stoma can be significant, and replacement is also important, especially when the stoma is in the proximal GI tract. Intestinal contents become progressively more solid as and when they pass through the colon to the rectum. Ileal and cecal contents, they are liquid and they are quite erosive to the skin. Contents of the transverse colon stomas, they're typically semi-liquid and they're less erosive. By the time it comes to the descending colon, they are solid and they're non-reactive with the skin. These generalizations are true when the proximal bowel has got sufficient length to allow the absorption of nutrients and fluid. But in children with short bowel syndrome, fluid and electrolyte losses can be massive, even if a distal colostomy is only present. Coming to the electrolyte composition of the enteral fluids, in particular ileum. So ileal fluid has got 130 sodium milliequivalents per liter of sodium. Chloride is 110 milliequivalents per liter. Potassium is 10 milliequivalents per liter. Soda bicarb of 30 milliequivalents per liter. And at the level of ileum, that is where vitamin C, folate, B12, vitamin D, K, magnesium, and various others, depending upon the transit time, are actually absorbed. Normal ileostomy output would result in the loss of 2 to 3 times the normal amount of salt and water, and hence these children are very highly susceptible to dehydration. Sodium and bicarbonate losses may exceed renal conservative mechanisms, and these infants are prone for dehydration, and they may not gain weight unless salt and bicarb supplementation is provided. Patients with long-standing ileostomies often have hypomagnesemia and a decreased absorption of vitamin B12 and folic acid. Patients with ileostomies also have a higher incidence of renal calculi and gallstones than that of general population. They may also have iron deficiency and fat malabsorption. Coming to dehydration. So jejunal and ileal fluid has got 80 to 140 milliequivalents of sodium per liter respectively. So that is evidence that many patients with an ileostomy, they are salt and water depleted. It comes from the observation that when we check their plasma renin and aldosterone levels, they're quite high. And also when we check the urine sodium concentration, it's often less than 10 millimoles per liter. Unrecognized chronic dehydration in these patients may actually result in end-stage renal failure. Hence the need for proper management with regular monitoring. Diuretics, if given to the patients with ileostomy, that can actually precipitate renal failure and hence must be avoided. Hypomagnesemia. The symptoms are usually fatigue, depression, irritability, muscle weakness, tremor, tetany if there is associated hypocalcemia, convulsions. Often it is asymptomatic even at very low serum levels of magnesium. In the long term, loss of bone density with risk of fractures and chondrocalcinosis may occur. The reasons for hypomagnesemia includes secondary hyperaldosteronism, removal of ileum and colon, which are the key areas in the gut for absorption. So free fatty acid malabsorption and taking PPIs. These are the other possibilities. Impact of oral NaCl supplementation on the thrive of the neonates and the intestinal microbiome in neonates with small bowel ostomies. A prospective cohort study was done, which included 24 neonates with enterostomies, wherein 19 subjects received oral NaCl and 5 subjects did not. And the result was those receiving sodium chloride actually had vastly improved weight gain and an increased abundance of lactobacillus in the fecal samples as compared to those who did not receive the same. So their findings actually supported oral sodium chloride supplementation as a mainstay of post-op treatment in infants with small bowel ostomies who are predisposed to suffer from sodium-depleted associated failure to thrive. They say that sodium chloride promotes weight gain by increasing glucose resorption and also helps to induce microbial restoration by enhancing the abundance of health-promoting probiotic bacteria. Adaptation of the bowel. Proximal bowel can adapt to the fluid and electrolyte losses of a distal small bowel stoma. The absorptive capacity of the proximal bowel would increase, and it can reduce the ileostomy electrolyte losses to 2/3 of the initial output. Adaptation of water absorption is a much slower process. Adaptation is thought to result from a mixture of hormonal, luminal, and mechanical influences that would induce the structural changes in the mucosa and measurable differences in the intestinal motility, permeability, electrolyte transport, and absorptive capacity. Mucosal hypertrophy and hyperplasia of the remaining intestine is the most cited explanation for adaptation. Hormones implicated in the adaptive process include mineralocorticoids, growth hormones, insulin-like growth factor, glucagon-like peptide 2, epidermal growth factor. Slowing the transit through the bowel would also increase the time that is available for absorption and is another potential mechanism for adaptation after colectomy. Changes in the small intestinal smooth muscle can also contribute to decreased motility. The most concerning fact is, however, ileostomy diarrhea and the subsequent nutrient depletion that occurs. So what is ileostomy diarrhea? What happens there? The causes of the same can broadly be placed into two contexts: the patient who never adapted and the patient who was previously well adapted, but he presented with a new increase in output. The traditional etiologies of diarrhea remains applicable to the ileostomy patient, including infections, osmotic diarrhea from ingestion of poorly absorbable substrates, celiac disease, and medications. The presentation is more dramatic because of the inability to compensate for the fluid loss by colonic absorption. So coming to the first category, that is failure to adapt. The reasons can be extensive ileal resection, IBD, enteric fistula, perioperative adrenal insufficiency, or idiopathic. Coming to post-adaptation, that is somebody who was previously well adapted and then he has a new increase in output. Various factors include infections, small intestinal bacterial overgrowth, various medications, structural causes like stomal dysfunction or stricture, intestinal obstruction, enteric fistula, ileus, lymphoma or lymphatic obstruction, autoimmune causes, endocrine causes, bile acid deficiency, osmotic diarrhea, radiation enteritis, pancreatic insufficiency, and other factitious causes. High stoma output in neonates is defined as losses exceeding 20 ml per kg in a 24-hour period or more than 5 ml per kg in a 6-hour period. Losses exceeding 20 ml per kg per day, they are associated with suboptimal hydration and growth. Losses frequently exceeding 30 ml per kg per day, they have been shown to result in serious complication as well as patient deterioration. Causes that may need consideration and investigation in babies with high stoma output include sepsis, malabsorption, short bowel, bacterial overgrowth, feed intolerance, prematurity itself, rotavirus vaccination, and intestinal obstruction. If left untreated, persistent high stoma losses can result in serious complications, including dehydration, electrolyte imbalances, poor weight gain, and failure to thrive. So coming to the fluid management in high output stoma, it depends whether the baby is less than 3 weeks post-op or more than 3 weeks post-op. For any baby who is less than 3 weeks post-op, the steps to be taken include: we need to replace all stoma losses that exceed 20 ml per kg per day. Stoma losses that exceed 20 ml per kg per day should be replaced intravenously with 0.9% NaCl with 10 milliequivalents of potassium given for every 500 ml fluid that is given. This replacement should be done every 6 hours. If the losses are higher, we can do the replacement every 4 hours. When stoma losses exceed 20 ml per kg per day, enteral milk feeds should not be commenced post-operatively unless given approval by the surgical team. If a baby has commenced oral feeds and stoma losses then exceed 20 ml per kg per day, do not increase any enteral feeds. Stoma losses should be replaced and close monitoring and documentation to be done. If losses continue to exceed 20 ml per kg per day, consider reducing or stopping the enteral feeds and increasing parenteral nutrition. Once losses are less than 20 ml per kg per day, we can restart the feeds. Coming to babies who are more than 3 weeks post-op, these babies should have losses less than 20 ml per kg per day. If there is a sudden increase to more than 20 ml per kg per day, in a baby who has already achieved and they were previously tolerating full enteral feeds, that needs close observation. Replacement of losses in these babies is not initially necessary, particularly if we don't have any venous access. For such babies, best to examine the baby and monitor for daily weight, maintain a strict IO chart, electrolytes, urine sodium level, stoma output and appearance, and also assess for clinical signs of infection. So persistent losses of more than 20 ml per kg per day or losses exceeding 30 ml per kg per day would require intravenous replacement with 0.9% NaCl with 10 milliequivalents of potassium for every 500 ml fluid that is given. Medical therapy can be initiated by the gastroenterology or surgical team to aid in the management of high output. Medical therapy includes ranitidine. Ranitidine is an H2 blocker. It will serve as an anti-secretory agent, reducing the amount of acid that the stomach produces, which will help to lessen the stoma output. Omeprazole, it's a PPI that will act as an anti-secretory agent, reducing the amount of acid that the stomach produces, hence decreasing the stoma output. Loperamide. Loperamide is an anti-diarrhea medication that reduces the intestinal motility and helps decrease the water and sodium output from the ileostomy. Cycling antibiotics. Bacterial overgrowth can happen in the small bowel. Cycling antibiotics that are not absorbed by the intestinal mucosa, they can treat the bacterial overgrowth and help against resistance. As an example, rifaximin alternating with metronidazole can be used every 3 months. Cholestyramine. It's a bile acid binder which will help to protect the colon from the caustic effects of bile acids that are passed through the ileum. Octreotide. Somatostatin antagonist, which will help to reduce salivary gastric, pancreaticobiliary secretions, and it will slow the GI transit. It can be given subcutaneously, IM or IV, that is not commonly used. GLP-2 analogs like teduglutide, that is an endocrine peptide which is released in response to the luminal nutrients. They will cause mucosal cell hyperplasia and hypertrophy. It is said to enhance intestinal adaptation, and it has been approved for use in children more than 1 year only. So the various nutrient deficiencies that the baby would be prone to includes carbohydrate, amino acids, fatty acid, fat-soluble vitamins like vitamin A, D, E, and K, phosphorus, selenium, magnesium, various water-soluble vitamins, sodium, potassium, chloride, vitamin B12, bile salts, zinc, short-chain fatty acids, and vitamin K. So coming to carbohydrates, protein, and triglycerides, the manifestation in the baby was primarily growth failure. Vitamins A, D, E, and K. A manifestation would be xerophthalmia blindness. D, metabolic bone disease. E, hemolytic anemia, myopathy, and neuropathy. Vitamin K can manifest as hemorrhage. Vitamin B12 manifestation could be megaloblastic anemia as well as ataxia. Folate, anemia, thrombocytopenia, glossitis, and stomatitis is possible. For those who are deficient in sodium, growth failure and tissue edema is noticed. Potassium, cardiac dysfunction, and muscle cramps may be seen. Chloride, growth failure, hypokalemic metabolic alkalosis. Magnesium, it may manifest as weakness and cardiac dysfunction. And calcium, metabolic bone disease, paresthesia, tetany, and cardiac dysfunction. So nutritional supplements that are required for infants with ileostomy. Coming to the various RD requirements, vitamin C is 30 milligrams per day, folate of 50 micrograms per day, B12 0.3 micrograms per day, A of 350 micrograms per day, D of 400 IU, E 4 milligrams per day, and K of 10 micrograms. The various minerals, magnesium 30 milligrams per day, iron of 2 to 3 mg per kg per day, phosphorus 60 to 90 milligrams per kg per day, selenium 2 micrograms per kg per day, zinc of 2 to 5 milligrams per day, potassium 2 milliequivalents per kg per day, and sodium of 2 to 3 milliequivalents per kg per day. Sodium deficiency is a frequent complication that occurs in neonates with high output stomas. They can impair the growth, and supplementation should help compensate for the sodium losses and restore growth. According to the requirements, 1 to 2 millimole per kg of sodium chloride solution has to be given daily in divided doses. Higher doses may be needed in case there is severe depletion. Surgical consideration should be made to ascertain if the person is a suitable candidate for recycling stoma losses. So what does it involve? It involves returning a portion of the stool into the distal stoma, that is mucus fistula, by using a catheter and syringe. It is thought to be beneficial in maintaining the patency as well as the functioning of the distal bowel, and for promoting the growth and intestinal adaptation prior to stoma reversal. A contrast of the distal bowel to ensure patency is needed before we start the recycling process. Summarizing the same, if the stoma output is less than 20 ml per kg per day, and the stoma is active and healthy and aspirates are minimal and non-bilious, we can actually start trophic feeds around 10 to 20 ml per kg per day every 2 hourly of express breast milk. If tolerated, we can actually continue to increase the enteral feeds and decrease the parenteral nutrition proportionately. Surgical guidance is advised. We should consistently monitor for the weight of the baby, fluid IO chart to be maintained, stoma output, and serum electrolytes to monitor. If tolerating enteral feeds and the baby is gaining weight, provide breastfeeding support and parent and family stoma care education. Prepare and normalize for reversal or transfer to the pediatric ward or discharge home. If the stoma output is exceeding 20 ml per kg per day and the baby is less than 3 weeks post-op, replace the losses that exceed 20 ml per kg per day. Continue parenteral nutrition. Do not increase the enteral feeds. If the baby is more than 3 weeks post-op, initially just monitor serum electrolytes, urine sodium, blood gas, IO charting, weight, stoma output, and appearance. If on parenteral nutrition, do not increase the enteral feeds. If the output remains high, reduce the enteral feeds and increase parenteral nutrition. If on full enteral feeds, continue NG feeds. Continue to monitor all the electrolytes, urine sodium, maintain the IO chart, wait, and observe for any clinical signs of infection. If the losses exceed 30 ml per kg per day, replace the losses. Do not increase the enteral feeds. Consider actually stopping the enteral feeds and increasing parenteral nutrition. Monitor serum electrolytes, blood gas, IO charting, daily weight monitoring, weekly urine sodium. Also look for the stoma output and appearance. Consider absorption difficulties, feed intolerance, bowel obstruction, and infection that may have happened. Medical therapy along the lines of ranitidine, omeprazole, loperamide, sodium supplementation, and cycling antibiotics are also to be considered. And all at the end of it, continue to monitor the electrolytes, urine sodium, IO charting, weight, and observe for clinical signs of infection. This has been taken from the Trust Guideline for the Management of Stoma Output in Infants.
Is it over?
Yeah.
Okay. So thank you, Dr. Aishwarya. So we decided to take this topic because even though it's a surgical topic, there's a lot of medical aspects to be taken care of. And this baby we are having currently with us is we are having difficulty in managing because initially there was a huge stoma output to the tunes of 80 to 100 ml per kg per day. The baby was consistently losing weight and sodium losses were there. And so we had to, with the consultation of the pediatric gastroenterologist, we started the baby on IV fluids. We were replacing the sodium. We started on H2 blockers. And also we started on polystyrene, and later on we had to start the baby on loperamide, following which there was a decrease in the stool output. We were continuing the baby on normal breastfeeds only, and we also started cycling oral antibiotics and started on oral metrogyl. So right now the losses are coming down. The baby started to gain weight, but still now the current problem is baby is having a prolapse from the ostomy site and needing reduction. Occasionally the site there is a prolapse. So that is a difficulty we are having now. Baby is still with us, and once the baby's hydration status improves and we are planning for discharge and elective readmission for corrective surgery at a later date. We did not consider elemental formula because here mainly I don't think we consulted with the gastroenterologist and continued with breastfeeds. We have an expert, Dr. Binu, who is an associate professor of pediatric surgery. So Dr. Binu, would you kindly give your inputs?
Thank you, madam. That was a wonderful presentation. These small bowel stomas are always very difficult to manage, especially the local complications as well as the complications due to fluid and electrolyte loss. Usually we close the stomas only after 8 to 12 weeks. But unfortunately, in this case, we may have to close the stoma early. So that's an early stoma closure we have to plan because of the high output as well as the local stoma complications. So first of all, we have to ensure that the distal bowel patency is good with the contrast enema as well as the contrast through the distal stoma. And once we confirm the patency of the distal bowel, we will try to close the stoma. The problem with the early stomach closure is that because of the leak and the peritonitis, the bowel will be edematous. There will be a lot of adhesions. That is why we wanted to delay the closure. But unfortunately, the child is still having high output fistula, and also there is a stomal prolapse. So we are planning to close the stoma early.
Thank you, Dr. Binu. I think there are some doubts, indications for correction of the prolapse. And
madam, prolapse, these are all temporary stomas. So anyway, we'll be closing the stomas within 3 months. The correction of the stoma, prolapse, it would be an unnecessary surgery in this case. Because we'll try to close the stoma rather than fixing the bowel. Fixing the bowel has its own complications like adhesions, and the next time you want to mobilize the stoma for close, it will be also very difficult. So usually we try to correct the stoma prolapse in case of colostomies where done for Hirschsprung disease or endometrial malformation, where the closure will be done by 6 months or 1 year of age, only after the definitive procedure. But in this case, it's better to go for a stoma closure rather than a prolapse correction for a prolapse.
The next question is, do you give any documents for the parents on colostomy site care?
Pardon? Madam,
we have written documents. Yeah, written. Is there asking if we have any written? We are actually, I think that's a great idea. Probably we can have something. It would be, because it is a bit frightening for the parents, and initially it took some time for this mother to adjust. She still has having worries. So we are teaching them, and now the mother is only at the bedside taking care of the baby most of the time, and she's confident in taking care. But as you said, probably giving a written down colostomy care package would be a good idea. So in the local language.
That's a good idea. Unfortunately, we are not doing it now.
They're not doing. Probably we can try. And if any other center is doing, they can please share. We have been teaching her how to use the zinc oxide, and as the innovation with the betel leaf nut. The leaf. Any words on that, Dr. Binu? We are using the betel leaf.
No, madam. No, they are not usually using the betel leaves.
Anyway, for this.
This is one of very few cases it was tried.
Yes, and
I think Bina madam, our professor Bina madam used it in a couple of cases.
Yes.
Yeah, Radhika, Srinivas Murki here.
Hello, sir. Hello, sir.
So I think very, very interesting presentation, and she has brought out two important aspects. I felt was the skincare was this betel nut concept is very good. Maybe it should be tried because it's culturally feasible. The second thing is adding salt. So I think that also she has given a physiological reason for it. I think it might be worth looking at that. For the skincare, we use duoderm. So do you use duoderm?
We are using duoderm, but here locally we have not tried it. We are using it for fixing tubes and the extra thin duoderm you're asking about.
Yeah. So if you use duoderm, it will be working almost for a week or so. You can have a large patch of duoderm. You can make a central cut and for the stoma to come out. So it's basically you're protecting the skin from the stromal irritants. See, the second thing is, I think if there is large amount of stool, you have to treat it like a chronic diarrhea. So first differentiate into whether it is osmotic or whether it's a secretory diarrhea. So that can be easily be done by stopping the feed for a day. And if the stool output gradually totally decreases, most likely it is osmotic diarrhea. Now, if it is osmotic diarrhea, mostly you'll have dealing with a carbohydrate or a reducing substance like sorbitol, other reducing substances are present in the stool. So you can also know the type of carbohydrate loss like frothy stool or greening stool, or these can help us to say that, okay, there is a carbohydrate loss. You can restrict the carbohydrates then. Fat losses are usually unlikely because it is not evident, but you can think of fat loss only if they're large stools or whitish stools. Protein losses are difficult to identify, but edema, hypoalbuminemia are features to say that there is protein loss. So we can actually judge if it is a osmotic diarrhea. We try to see whether it is carbohydrate, protein, or fat loss, and you can correct appropriately. And if there is a secretory loss, then all these other things, neuroendocrine medical treatment is going to be very useful. Like she has told about ranitidine or omeprazole or the UDCA. Another UDCA also can be used like cholestyramine. So these are other things which can help you to decrease the stomal losses.
So we did give a trial of NPO for 24 to 48 hours, and there seemed to be some reduction, but it was not major. Then that is when we went back to breastfeeds, and we didn't consider any other elemental formulas as some people had suggested. And then we had to, as per the gastroenterology opinion, we added other drugs, like you have said, cholestyramine. And this is the first case where we never tried loperamide before in high output stool output. But in this particular case, because we were pushed to the wall, we had to start, and it did work actually for this baby. So temporarily we had to give loperamide too.
I understand. The other thing people have tried is resicadotrine. So like in a very high stool output, resicadotrine can also be tried.
So is there any role for any ostomy bags? Like they're very expensive, and I know in our setup they may not be very feasible.
So
Anybody has any experience with ostomy bags?
We have tried using ostomy bags. As you said, it is very expensive and the maintenance is very costly. Although what happens is the person comes and explains to the parents how to take care of it. But the same problem, what happens, the base, if the base is gone, they have to replace it with a new bag. So the base has to be staying for long, and that's not easy. In adults, it's slightly easier. Probably in the skin of the newborn also, the stickiness is not that good. So obviously these, they lose the base and then they have to replace with the bag. So overall, most people are happy with a lot of coconut oil application. And again, coconut oil is very good for the ostomy care. So I think that also can be considered. The second thing is when you use
plenty of coconut here.
Coconut oil, yeah. The second thing is actually when you use Siloderm, you have to tell them apply like a thick paste, not just it's not like a cream. It should be applied like a paste, so that it's basically
it should be like a toothpaste consistency.
Exactly. Yeah.
So there are some questions on, I am actually not very sure, maybe the surgeons, any role for Adapt paste and Karaya paste? I think probably local application. We don't have any experience with that. Dr. Binu, are you happy with the zinc oxide or anything else that you have tried?
No, ma'am, we only use zinc oxide. Then one Coloplast powder is available. We used a couple of times. That is for peristomal excoriation.
Since Dr. Binu is a surgeon, Dr. Binu,
Yes,
in NEC, if you're doing an ileostomy for NEC, do we really have to wait for some time before closure? If there is the infection has come out and colostomy is working, how long do you need to compulsorily wait? So is there a fixed time for NEC and ostomy?
Yes. So usually we wait for at least 8 weeks to 12 weeks. That's the usual time we wait. But there are a few studies comparing early closure compared to the late closure. They say it's a comparable complications only. So you can try early closure, but in our institution, we usually follow the late closure only after 8 weeks.
In this particular case, we are planning on an early closure.
Yes, madam. This is the case.
So there are some ostomies which have lasted for a long time and TPN. If you go to the Western literature, they keep them on TPN for months together. So especially the jejunal atresia, these are the most difficult to treat.
Yes, and this is the one here in this particular case also, sir. That's the same thing.
So in jejunal atresia, in fact, I always tell that whenever we diagnose jejunal atresia, it's a long journey. It is in months. So sometimes you have to give TPN for ages, and there is nothing like gut transplant in the newborns. We had one baby where we had to even explore the possibility of a gut transplant, but we came to know that even in UK, the waiting time is about 2 years. So I don't know, Dr. Binu, any gut transplant options in the country?
Sorry, so no, not much experience.
We talked to the pediatric. We had a discussion. The pediatric, he was, and the gastroenterologist, and he was also saying that is the final option, but unfortunately, it's not available in India for neonates at least. Are there any more questions from the? Somebody had suggested giving a colostomy care document to the parents, and we are not doing that so far, but I think that's an excellent idea. We could start doing that because it's a
yeah, I think it should be done, and maybe Aishwarya, who has presented today, she can make a document and send it to everybody.
We will do that. We can do that, and everybody can translate in their own local languages. And
wonderful. I think that will be one good output of the presentation. Yes.
So even though this is a surgical case, because we are left managing many of the medical complications associated with this, we thought it was worthwhile discussing. And I would like to thank all the participants and Dr. Binu for giving his expert comments. And of course, special thanks to Srinivas Murki sir for joining in and giving your expert comments. Thank you so much, sir. And congratulations, Aishwarya, on the good presentation. So are there any more doubts or can we wind up? Okay,